coming and dying. And if you notice the pods with the bags, it's a dialysis solution. The hospital didn't have the capabilities. Of course, they had the nephrologists trained and the knowledge, but didn't have the funding to offer these patients modern dialysis treatment. So they had to rely on obsolete dialysis techniques. We're talking 20, 25 years ago. But I quickly noticed that something was different. The kidney patients, they were not following the script according to the nephrology textbooks. There was something different because the book said that they should be half and half men and women, and they should be elder people, 70 years old, 80 years old, but they were quite young, and there were lots of men and some women, yeah, but it was mainly men, young males, and they were coming and they didn't have any kind of records or backtrack or nothing. So I started asking questions. So why is it so? And everybody said that that was normal, that was usual. So you have to keep this in mind. 25 years ago, the personnel, healthcare personnel, thought that it was already normal. So the epidemic obviously predates the first description. So survival was short, mortality was high, but more patients kept coming, and there was no information, zero information. So we decided to do a small study, and the results from this descriptive study of new patients attending the emergency ward, because they were all coming from the emergency room. None of them was programmed. None of them actually was attending a dialysis program as it should have been. So only 33% of them were standard CKD patients, but most of them, 2/3, they were quite peculiar. We were not able to identify the cause of their kidney disease. They seemed to came from very specific regions. They were younger than expected, and most of them, nearly 9 out of every 10, were male. So we concluded that we were facing an abnormal incidence of end-stage renal disease driven by an unknown cause, possibly due to pesticides and or a heavy metal, since 2/3 of them were agricultural workers. We published it in 2002, and quickly, suddenly, people from the coastal regions, from the Bajo Lempa, came to see me and to ask about the study and to what to do. They didn't know what to do with their deaths and all the people that were dying.
Sorry, Ramon, to interrupt you.
But we didn't have a clue back then. So one of the group of people that came to seek for assistance were the people from the Emergency Social Fund for Health of Tierra Blanca. It's a community organization born from the Catholic parish of this little town of Tierra Blanca, near the Bajo Lempa region. And we were able to get 3 or 4 kidney biopsies and send them to Barcelona for analysis. And the pathologist, he was surprised because I can still remember his words. He said, "I can't tell you what this is. I can tell you what it isn't. This is not diabetes. This is not high blood pressure. This is not heavy metal. This is something different. Something's happening here, and I don't know what it is." It was back in 2003. So we tried to test the first hypothesis that we came up with, and we did a multivariate logistic regression, but only the region showed association. I mean, living in the coastland against people living 500 meters above sea level, they were doing the same crops, they were using the same pesticides, but they didn't get the disease. So something else was happening. We were not sure. Then in 2005, there was a paper from Manuel Cerdas, our colleague from Costa Rica, describing a high prevalence of CKD in young males in Guanacaste region in the Pacific coastal coast of Costa Rica. In 2009, the first studies from Nicaragua by Boston University began to become public. We were aware of them. And in 2015, Guatemala, also from the National Institute of Social Security, they had some publications describing the same phenomenon that we were watching, that we were living with in our country. There are other regions that we suspect that may have also have the disease, but we're not sure yet if it's the same thing or it's a false signal. Recently, there have been some case reports from USA, but mainly from migrant workers. They are not actually native people living in the United States, but people from our countries that immigrate looking for a job, and they get sick there. And our colleagues from the United States, they report the situation. So voice men, it's a new form of CKD, an endemic nephropathy and I'm going to talk like a nephrologist here because that's what I am. I know I'm an epidemiologist. I'm not a researcher, actually. I am just a nephrologist. So I'm going to talk like one. So for us, for the nephrology community, this is an endemic nephropathy. The cause is still unknown despite many hypotheses proposed and tested, and seems to occur in very specific hotspots along the Pacific coastlands of Mesoamerica. It's mostly young males. There's a frequent family history of CKD, of chronic kidney disease. It's a rapid progression if not diagnosed timely, and it's aggravated by strenuous work and heat stress. And I'd like to extract this out. We see patients on any occupation, not agricultural workers. And I have put some references here of studies demonstrating that the disease is also present in other occupations. It's not exclusive to agricultural workers or sugarcane workers, as we may have thought at the beginning. Well, actually, the first report from Hospital Rosales, it was only 2/3 of them who were actually farmers. So we have to keep our eyes open and look for these patients. The only important specific characteristic is that they live there in a hot spot. So the clinical findings, basically, it's been 20 years attending these patients, and we know something now. We know that they don't have the traditional causes of CKD. Their blood pressure is normal. Should be high because that's one of the multiple works and jobs that the kidneys have in our organism, in our body. Kidneys, apart from being a filter, filtering the blood and producing urine, getting rid of urea and potassium. Also, the kidneys have so many types of works in the body. They control blood pressure. So blood pressure usually gets out of control when the kidneys fail. They control the amount of blood. So we usually have anemia when the kidneys fail. They activate vitamin D, which controls calcium and potassium, and they also keep the balance between the acid and the alkali in the body. So these patients, we see normal blood pressure, which is remarkable because it's not the standard, the traditional chronic kidney disease. We see low proteinuria. The level is quite low, like any tubular disease. We don't see edema. Actually, these patients attend dialysis and they are dehydrated instead of having edema. We also see low potassium, high uric acid, and low sodium, and sometimes urate crystals in urine, which we are not actually sure if they are something specific to the disease or is just another characteristic of our populations. Regarding the clinical characteristics, the SLAN Committee for Mesoamerican Nephropathy's regional survey to 60 nephrologists attending these patients tried to validate the criteria that were published some years back, 4 years ago actually now. It's been 4 years since these criteria were published, so we may need to make an up-to-date about this, but it was a great collaboration coordinated by the Latin American Society of Nephrology, Alejandro Ferreiro, and many colleagues from the region. So they did this confirmed clinical case of chronic kidney disease case definition for surveillance. The importance of this paper is that it's a clinical case definition, basically. So with the coordination of Dr. Zulma Cruz de Trujillo from Hospital Rosales, the SLAN committee did a a regional survey. 16 nephrologists responded positively and filled the survey and completed all the data. And what we found was that I'm going to talk only because this is a lot of data, but I'm going to talk about those who responded always or almost always when asked about their daily practice with their patients. So the answers were this. Patients live on the Pacific coast, 90%, Costa Rica, Nicaragua, Guatemala, Panama, El Salvador, even Mexico, Honduras, and they said 90% said always or almost always, which is interesting. The majority of these affected patients are young men, and 92% said yes from our colleagues. They work in open places with high thermal exposure. 96% of our colleagues said yes. Patients perform strenuous physical work. 95% of the colleagues, the nephrologists, 16 nephrologists said yes. And regarding the clinical characteristics, well, this is a little bit more of a, not that clear. It's uncharted territory yet, because CKD is usually asymptomatic. Well, actually, we thought that the disease was asymptomatic for many years until we started the early diagnosis campaigns with the Emergency Social Fund for Health of Tierra Blanca, the Bajo Lempa region 15 years ago. We realized that it wasn't asymptomatic at all, but mostly it seems to be asymptomatic. The patients have asthenia. Even now, 48% of the colleagues think that these patients are asymptomatic, but we start to notice a pattern that is so similar to any clinical picture of dehydration or AKI, acute kidney injury. I'm going to refer to acute kidney injury as AKI from now on. So they refer cramps, paresthesia, necturia, and dysuria if asked for. And what we find with the lab tests is hypokalemia, hyponatremia, hyperuricemia, which is quite common. So actually more than what we would expect from the standard kidney patients. They say 51% on early stages of kidney damage and 85% when they approach dialysis, and of course, anemia. So we have to differentiate the patient attending the clinic and the patient that goes for the very first time to a hospital, because they are two different types of patients. The first is the one that we attend at the clinic, the consultation. And the most frequent consultation causes are cramps, fever, what they say it's a fever, but it hasn't been actually measured or demonstrated to be a fever. Weakness and dysuria. Dysuria is quite common. Aseptic dysuria with negative culture. The referral cause is usually a community screening. Well, this is my personal experience because I work with the Emergency Social Fund for Health, and they do monthly screenings. They visit the communities trying to diagnose new cases. So we find a high ACR, which means albumin creatinine ratio, which means proteinuria, even low, but it's proteinuria, it's present. So if they find a patient with proteinuria, they send it to me. Or if they find a low GFR, a glomerular filtration rate that is under normal, they send it to me for evaluation. Or some patients even debut with an AKI clinical picture, which is the acute kidney injury, which is a different beast from chronic kidney disease. So, and the profile, they are young males from the hot spots, and they often have a family history of chronic kidney disease too. Actually, I have a couple of patients that have been sent by their mother because she already lost 2 or 3 of her sons and the husband, and they say, hey, this is the last one I have. This is the only one, so please, doctor, check it out for me. So this is the other picture, a different world. My colleagues that work at hospitals will be more familiarized with these patients. The consultation case, they attend the emergency room in such bad conditions that it's unbelievable they are still alive and walking through that door. And they say, I can't work anymore. That's the main reason why they go to the hospital, because they can't work anymore. Second, vomiting, disoriented, and other uremic signs and symptoms. The debut, the referral cause, usually they are self-referred, or they are referred from the basic level or the second level of health assistance. And the profile of these patients, they are older. They're 45 to 55 years old, according to the, there's just a couple of studies that have tried to look at this. One hospital-based and community-based study looking at end-stage kidney disease patients. So the age, they are older, of course, because tubular diseases often progress slowly with time. And they come from a hotspot and they don't have any previous records. Actually, most of them say, this is the first time I see a doctor in my whole life. Do you have high blood pressure? I don't know. I never had my blood pressure measured. So it's curious. They've never had the opportunity to receive attention previously. And they are extremely uremic. And when I say extremely, I really mean it. Well, look at this. This creatinine level, 45.8 milligrams per deciliter. This is the type of patients that we receive for the first dialysis. It's even hard to get a past history well done with this kind of, they are so sick when they arrive. And I was kind of proud of this picture, but then I was in Costa Rica when one of my colleagues, Dr. Aveyan, she showed me this other one from Costa Rica, 51 milligrams. So they really go to die to the hospital. So when I say specific hotspots, I really mean it too. Because if you look, and these are two different sources, and it's good to have the same information from two different sources, from two different indicators. The first one to the left, you will see the mortality due to chronic kidney disease from 2011 to 2015 in El Salvador. And the red, we have 262 municipalities, which are small pieces of the country. And you see in red, those municipalities with higher rates of mortality. Then in the middle, you see the prevalence of patients attending dialysis or transplantation. It was an incomplete set of data. We missed origin information for about 10% of them. But even then, we have a similar picture to the mortality map. And then to the right, you will find the average temperatures, the maximum temperatures, sorry, of the territory of El Salvador. I'm showing you this because this is what I'm most familiarized with. And the maps seem to match. Obviously, correlation doesn't mean causation, but it's obvious. It's so obvious we can extrapolate it to the whole region. If we check the maximum temperatures of the Central American regions, we can pinpoint the hotspots of many patients. The only problem we have is that we don't have official kidney renal records or a renal data system. So we don't have the whole picture. But what we have seems to match. Main hotspots seems to follow heat, which doesn't mean that heat causes CKD. It just means that patients come from the hotter regions, and we have to find out why. These are the patients that I attend from the Bajo Lempa region. To my left, you have Sat. I will not say his name, but he gave permission to use this picture. And he is a truck driver. It's curious, I've had him in control for 5 years. He's behaving well because we got him on an early detection campaign. So we hope that it will be 5, 10, 20 years until he reaches dialysis. We hope so, if he sticks to the treatment and attends to the consultations, which we give free of charge. But he's a truck driver. And to the other side of the screen, you can see two of the members of the Sanchez family, the Bajolempa, they are not agricultural workers too. They are shrimp cultivators. They belong to a cooperative. And they both have the disease, CKD. I took care of Rogelio's father. He's with the heart. And I have his permission to use his name. I kept him under control for 14 years. Then he had a fever, mosquito-borne fever, and he went to stage 5 to dialysis. Obviously, he couldn't afford dialysis, and he died. Now I'm taking care of his son, who is currently on stage 3 of CKD. In the Bajolempa region, people already know which families have the disease and which don't. And so many strange things happen because they tell their daughters, hey, don't marry that family because they have CKD. So if not diagnosed and treated timely, it seems to progress quite fast to end-stage renal disease, to dialysis. And we have 2 studies, one from Marvin Gonzalez in Nicaragua, and one from Fisher from the Baylor College of Medicine about this situation. But when we get them on an early stage and we take care of them, they seem to progress slowly, or the progression seems to halt. But we are not sure about this. We haven't had any funding to do an important study about this, if the treatment that we are using empirically actually works or is just a placebo for the physician and the patient. But it seems to work because we have patients well treated and under control for 15 years now. That's the experience we have. So the cause, the answer is simple. We still don't know. We've came up with a rogue of possibilities, from pesticide exposure to heavy metals, occupational exposures, something hereditary, heat stress, dehydration, uric acid, infections. But we still don't know, and we have to keep working and investigating. And all these lines are open for investigation. But I'm going to try to shed some light now about the cause. I'm sure the next webinars are going to expand further into the causes or possible causes, so I'm going to be quick about this. So to date, no single hypothesis has been able to explain the disease. This is true. And currently, we think that at least 2 factors are required. The double hit hypothesis, and I want to share this with you. This is a collaboration with SUNY, Upstate Medical School of New York. So we think that first there's but this is we are working, collaborating with them, but this idea, I know that it has been in the minds of so many of us for quite some time. But it's the people from SUNY that are trying to make sense of it. So the first thing is a predisposition, a tubular lesion. These people, they get hit probably when they are young kids in early childhood. And maybe that's why we haven't found the cause, because we've been looking at the adults. We've been looking at the second hit. So since they have a tubular lesion, they are susceptible to dehydration, and they can't tolerate heat stress or physical exertion. They can't concentrate urine, so they get dehydrated easily, quite easily. So we are still not sure, but if heat stress is related to this disease, then we are facing a big global problem. So the next item on the presentation is Sri Lanka and Udanam endemic nephropathy. Again, I'm talking as a nephrologist. I'm not an epidemiologist, or I am not an expert on public health. So I always see the disease from the nephrology perspective. And to us, there are many examples of endemic nephropathies around the globe through the history of nephropathy. The Balkan endemic nephropathy, the Jinsu River nephropathy, itai, which was caused by cadmium. Itai in Japanese is ai, ouch, it hurts. Yeah? because cadmium accumulated also in bones and produced pain. In the Queensland endemic nephropathy in Australia, which in the end was caused by paint with lead. So they were all considered CKDUs, chronic kidney disease of undetermined origin at first when they were identified, but later the cause was identified. So many is an endemic nephropathy. That is how we see it from the nephrology community. Some endemic nephropathies still are of undetermined cause, and we call them CKDUs, like the Sri Lanka endemic nephropathy and the Mesoamerican endemic nephropathy. But we're also not sure if every CKDU is Mesoamerican nephropathy or not. So it's quite adventurous to try to attribute findings from one nephropathy to the other when we still are not sure that they both are the same disease. In my personal opinion, they are. And in the end, we will be able to demonstrate it. The differences will dilute, but currently we are not sure. And if they are all the same entity, then we have a global problem. If you look at this image here, this map, and to the right of the screen, you will see a great article from Anirban Ganguly. And I really invite you to check it out because he describes the similarities and differences from Udanam nephropathy in India, Sri Lanka nephropathy, and Mesoamerican nephropathy, and the situation in Egypt, which hasn't been described quite as good as the other ones, but there's something also happening in Egypt. But if we put those dots in the map, the global map, what we see is that all these nephropathies are comprised between the equator and the Tropic of Cancer. That's quite interesting. And the other article that I really recommend you to read is from Wistrom, and the morphological and clinical findings from both Sri Lanka and Mesoamerica, comparisons, similarities, and differences. So I don't want to talk for my colleagues from India and Sri Lanka. It wouldn't be fair. Instead, I will try to talk on behalf of them and bringing back what we heard from them during the workshop, the last CENTEM workshop last year. And what we heard was a very similar picture with slight differences, but very similar. And this is what they said. This is what they had to say, our colleagues from India, Sri Lanka. So there are some slight differences, but I'm sure that time and knowledge of the disease will dilute these differences with time. And the research priorities and clinical management and counseling recommendations that the group brought out are these. And I want to thank Nathan Raines for his great effort to put all these separate ideas together and bringing them into a poster that we presented at the ASM Kidney Week last year. So if this is an epidemic, and we're finishing right now. Well, the starting point is unknown. So we use the word epidemic in a layman's sense because we don't have a baseline to declare an epidemic because there are no renal registries in the afflicted countries. And that's the big problem with our countries, poverty and lack of organization. But some mortality trends, as demonstrated by Katarina Wesselin from Costa Rica, show that main hotspot in Costa Rica apparently show from back to the 70s, a long time ago. But back then, the other countries, we had civil wars, we had poverty, we didn't have nephrologists. And during the 70s in my country, there were only 4, and all of them were located in the city, but this was happening in the Pacific coast. So nobody could diagnose CKD, it's simple as that. And if you look at this graph, you will notice that the life expectancy in our countries was so low that these people barely reached 50 years old before they died on average. They didn't reach the age to develop ESKD and ask for a consultation for dialysis at the hospital. they were already dead from other causes. So our case is really increasing. I hear this expression so often that there's an increase in cases. Well, in my opinion, no. It's the registry that is increasing. It's the awareness that is increasing. It's the active search for cases that is increasing. If we look at this mortality and end-stage kidney disease incidence graph from the Bajo Lempa region for 10 years, you notice that the incidence and mortality rates more or less keep steady. The amount of cases, it's the same during all this time. It's just that we didn't notice previously, possibly. So even though we have extreme end-stage renal disease incidence and mortality rates at the Bajo Lempa region, the incidence is well over 1,400 people per million population. And the annual mortality is 128 per 100,000 population. That's a lot. And 90% of them are male. So according to official data, in El Salvador alone, which the population is about 6.5 million inhabitants, we have at least 2,500 deaths attributable to CKD every year, half of them to men. This is a silent massacre. There's a lot of people dying. We have a lot of people dying, and we have to do something about this. And this, it's independent of the cause. It doesn't matter if it was diabetes, high blood pressure, or Mesoamerican nephropathy that destroyed your kidneys. If you live in El Salvador, you're going to die because you don't have proper access to healthcare treatment on kidney diseases. And if you look at the mortality in Latin America, the scarce data available, you can see that we have the mortality, our mortality is 6 times over the continental average. It's a lot. And then every year we are fighting for the first worldwide place with Nicaragua. Who has the most deaths from CKD? El Salvador and Nicaragua. Every year we are fighting for the first and the second place. And this is abnormal, extreme. But if you look at the males only, it's even worse. So our patients die from poverty and lack of healthcare, not from CKDu itself. And you can see that chart here with the modality of peritoneal dialysis in our countries. This is recent data from a couple of years back. And you see that most of our countries still rely on obsolete dialysis techniques. And I insist, this is not because we have problems with our colleagues. No, they have been well prepared. They have the knowledge, they have the know-how, but they don't have the funding to attend these patients properly. They multiply, they make miracles with the little funding that they get to attend these patients. So sometimes it's okay to be upset, but beware, because we have to do something, but with science. It's important that, as the colleague said, we need to take the heat out of the CKD debate, and we need to generate more evidence. Absolutely. So the takeaways, finishing, and this is the last slide. Evidence is still scarce. We have a lot of work to do. Means an endemic nephropathy, a new type of CKD, it's relevant. It's important. It's a public health problem. We are still not sure if all CKDUs are a single entity or not, but in my opinion, in the end, they will be, possibly. Sri Lanka and Udanam endemic nephropathy could be the same disease. There's frequent family history of CKD, but beware. Because remember Balkan nephropathy. I mean, in Balkan nephropathy, before we knew the cause, we were watching the same picture. A lot of family history of CKDu, but you don't inherit the bad genes only. You also inherit the bad practices sometimes. So the clinic We see young males, low or no proteinuria, low potassium, high uric acid, and I grade this out because it's not the same in India and Sri Lanka. Uric crystals in urine, physical activity, height, stress, absence of standard causes of CKD, and what's the most concerning aspect of the disease, the high mortality rates, not due to the disease itself, but to the excess of patients and the lack of adequate funding for treatments. So thank you very much. This is one of the meetings, the meeting that we had in Guanacaste during the SEMCAM workshop in collaboration with SLAN. It was a great experience, and I learned a lot from our colleagues in Costa Rica. And this is part of the work we are doing right now, a longitudinal study with the Boston University. They are so professional, and we're so happy to work with them. And I have to say big thanks to Dr. Emmanuel Harking. He's on the fields right now doing the nasty, the dirty job, so I can be here sitting, talking to you. And well, you are invited. Welcome to El Salvador. We have a beautiful country and more than 100 volcanoes. So many that we actually dive on some of them. Thank you so much.
Thank you, Ramon, for this very great presentation or talk about CKDu. And thank you for everybody for joining as well. If you had any question, you can ask Dr. Garcia-Trabanino, or you can send your question to us by the chat, then we can ask to him. You can do it in Spanish or in English.
I think there is a question, Marvin.
Mm-hmm.
Someone is asking, to reduce mortality rates, what is the first most important thing that needs to be done?
Well, that's a great question. I have asked that myself. I think the first thing that we need to reduce mortality is to acknowledge the problem. If we don't acknowledge the problem, the policymakers, the authorities, they won't invest on an invisible situation. So we have to make this visible. And one of the first tools is the renal registry. We need that desperately. Renal dialysis and transplantation registry to show the authorities the relevance and the situation and the mortality. Because there's a lot of people that still today don't believe that the mortality rates are as high as they are.
And there is, Ramon, another question that was posted by Dr. Gerardo Arroyo. Would you comment about the number of nephron at birth being less in patients born from very poor families?
Can you please repeat the question?
Would you like to comment about the renal reserve being less in patients born from very poor families, for very poor or low income families?
Yes, of course. This is like transplantation. The bigger the kidney, the longer the life expectancy of the kidney that we put inside. So obviously, a low weight at birth, malnutrition during early childhood, it all affects, obviously, but they are not all affected. So obviously there's something else, but poverty, these are social determinants.
Do you have any comment about this hypothesis, Ramon, about the lost birth weight? I was reading a paper that came out some months ago that was conducted in Europe about the association of lost birth weight in CKD when they get older. Do you have you seen any case with this kind of problem or relationship in your country?
Well, I can only talk about my personal experience with my patients. And if you saw the pictures, yes, I have patients with that are not tall, but I also have patients that are even higher than me, 180, 190. And if you've been on the fields, Marvin, and you take a look at these workers, and they are actually they are athletes. They are high intensity athletes with enviable bodies. So not all of them have malnutrition. And when we perform an ultrasound sonograph study, in early stages, I'm talking about stage 1 or 2 of kidney disease, we see normal kidneys, 11 centimeters, 10.5 centimeters, with quite nice cortex. So some of these patients, yes, I'm sure that they are affected by the low nephron count, but not all of them. It's not universal.
I have a question. Ramon.
Yes.
This is Gerardo Arroyo from University of San Carlos.
Gerardo.
I was asking about the renal reserve, referring to the number of nephrons that a boy is born with, and taking into consideration your hypothesis that this is a two-step disease. Could that be helping the vulnerability of a patient who is born with fewer nephrons and then exposed to other injury effects, environment, or drugs or whatever that will develop the disease in this already vulnerable patient?
Yes, of course. I said this is one of the factors that we have to care about when attending these patients. But correct me if I am wrong, but one of the main indicators of the nephron count, it's the kidney volume. And as stated, and as I said previously, not all of these patients have small kidneys to begin with. So yes, in those who have small kidneys due to whatever affects them during their childhood, obviously they will seek faster and they will progress faster to end-stage kidney disease. I don't know if that's what you were trying to ask for.
Hello, Ramon. I got a question. It's Fabio from Costa Rica.
Fabio.
I'm going to make the question in English, but if it's not a problem, I can repeat it in Spanish. Ramon, 2 years ago, I'm working with an insurance hospital here in Costa Rica, and we are very interested in this pathology because we're receiving a lot of patients from the hotspot in Costa Rica, from Guanacaste, sugarcane workers, and they're coming to us in early stages of chronic kidney diseases. I mean, I have patients with 1.5, 1.8 of creatinine, and with many frequent episodes of heat stroke problems. So my question is, in your experience, what are doing with the patients in early stages? I mean, more than the hydration, all the measures that you have mentioned, pharmacologically, is there anything that we can do? Because I had the opportunity to make at least 5 biopsies, And in 4 of that biopsies, I found tool interstitial nephritis. So some people say, why don't you use steroids in that patient? So I would like to know, what are you using pharmacologically in these patients? Thank you, Ramon.
Thank you so much, Fabio. Well, 2 things into consideration. First, we follow KDIGO and KDOKI guidelines. That's the first thing. But we have to keep in mind that these patients behave differently. I mean, you can't restrict potassium or protein in their diet, you know, because they have low potassium and they don't have a high blood pressure. So it's we don't use ACE inhibitors that often. So, but we try to follow the KDIGO guidelines always, and we usually end up first correcting the low potassium with potassium supplements. Yep, we have one locally available that I'm not going to say the commercial name, but I can tell you later. Yeah, so it's a potassium supplement. You drink it, it tastes horrible. So we recommend to dilute it with orange juice or something. Eat a lot of fruit, which fortunately enough, we are in the tropics. So we have access to lots of fruits. And once we correct the potassium, sodium seems to normalize by itself. But this is a personal observation. And when we have potassium corrected, we start bicarbonate according to the KDIGO guidelines. Not before, you know why? Because it would enhance the loss of potassium. No? But when we correct potassium, we start bicarbonate, and we give them education. If they have proteinuria, A2, then we give some education about heat stress and never getting dehydrated in order to use small doses of enalapril or a protector. But it depends on blood pressure and proteinuria, and it also helps us to bring up the potassium. But every case is different. It's hard to tell. We have a protocol for diagnosis and management right now, and we are working with the SLAN committee to get some guidelines published soon. But there's nothing that there's no systematic study to demonstrate if this actually works or not, as I said. But mainly that's what we use. The other thing, apart from correcting potassium and using bicarbonate, which actually seems to improve dysuria, curiously enough. So, and the other thing that we use is allopurinol to bring down the levels of uric acid with these patients.
Thank you very much, Ramon. Hope to see you soon, buddy.
So do I.
Ramon, there is another question. Are there a study of males from affected families who had moved out of hotspots? Are they predisposed to other type of kidney disease?
Well, in my experience, I haven't seen a family affected outside a hotspot, first. And then second, we've done many tests for Fabry disease on these patients because there are many similarities, despite the proteinuria, but the family component, males, we've explored many possibilities, including genetic diseases, but to date with negative results.
Okay. There is another question, but I think you have to talk about already. Do you know some experimental treatment that suggests any benefit? You have been talking about allopurinol and bicarbonate as well. I don't know if you want to comment again on this, or do you know about other clinical trial that is ongoing in Central America or any other country that is affected by CKDu?
Well, that would be great. It would be amazing to have funding to actually run a systematic study to demonstrate if what we're doing actually works or not. That's quite important. That's one of the needs, the requirements that we have right now. But the other thing is that we, in the end, we use whatever we have at hand. Sometimes we don't have allopurinol. We've used febuxostat, I confess, to lower the levels of uric acid. And well, we get good results. It's the same thing as using allopurinol. But apart from that, honestly, I am not aware of any other treatment. I mean, from a nephrology point of view, I know there are other interventions. There are some mills, sugarcane mills, that have been distributing water for the last 15 years, you know. There is an important effort trying to bring water, rest, and shade to the workers. And we are yet to see if this really reduces the amount of, it reduces the incidence of kidney problems. But the logic says, yes, it should. And also, we give a full counseling session to the patients, not only about water or medications, drugs, but also about any possible hypothetical or demonstrated or hypothetical risk factor. And it includes exposure to pesticides, nephrotoxic drugs, painkillers, antibiotics, and agricultural chemicals, everything. We tell them, take care of yourself, avoid unnecessary exposures. There's another question. Laura says if this presentation is going to be available for people who could not be able to connect today. And my guess is yes. Marvin, is it going to be available?
This presentation will be available soon. We are recording the presentation and we will post the link to the SENCAN website as well. Dr. Javier Estrada from Costa Rica share a question for you. It's interesting to know, to hear your thought about the lysosomal inclusion finding that was, this finding came out recently in a paper that was published in the International Kidney International Journal. Are those inclusion just indicator of damage, or do you think it really tell us about the cause? Do you have any thought about this, Ramon?
Yes, well, this is a promising field for exploration of future research. It was a boom 1 year ago, more or less, when it started sounding and bouncing from one side to the other. There was even one media in Sri Lanka, I guess, saying that they have found the cause. But in the end, it was just a pathological finding. We are still not sure of the real meaning of this. It seems to be related. And it would be so important if we could demonstrate that this is actually pathognomonic to the disease. It could be an important diagnostic tool for the pathologists for the disease to be identified. But I think that just like everything in science, we need independent verification, and we need to dig a little bit deeper into this finding to really be able to tell how significant it is.
I think Fabio has a question.
No, sorry, I already made my question.
Oh,
Thank you.
sorry.
I think we don't have more questions here. If somebody else has any question that we want to ask, that you want to ask or to share with us, you can feel free to post it or to jump it.
Ramon, my last question. You mentioned a couple of patients of yours, one being a truck driver and the other one being not on an occupation not related to agricultural work. With this, you're saying that the presence of this disease in sugarcane cutters is just a matter of coincidence because of the large numbers of workers in this exposed to strenuous work cutting cane? Is just a coincidence? Is not related with heat stress at all?
No, I'm not saying that it's a coincidence or that it's not related to heat stress or some exposure to a chemical. No, I'm not saying that. What I'm saying is that the most important thing here is the region. You live in a hotspot, you get sick. I have football, soccer players, athletes, patients. They have never worked in their whole life and they have the disease with all the clinical picture. And they have Mesoamerican nephropathy or CKDu. I can talk a little bit more about my experience with patients from the Bajo Lempa region. We have a registry of incidence and mortality going on from 2004 to date. It's still running. So we know these patients. And we have a census. The last census that we did in the region was 2014. We had 19,223 inhabitants from 42 communities surrounding Tierra Blanca town. And we know the households, how many households too. And about 80% of the households where they depend on agricultural work, but 20% they don't. We have shrimp cultivators, we have teachers, policemen, any occupation, truck drivers, construction workers, etc. So we have 80% of agricultural workers in these communities. And obviously we have 80% of patients are agricultural workers. But since the very first study, and I showed you 6 references, I could have put more. But since the very first study, when you do community studies or hospital-based studies, you will notice that it's only 65 to 80% of the patients who are farmers or agricultural workers. There's always a 20%, 15, 25% of patients that are involved in any other occupation and they have the disease. So I think it's more related to the region other than the occupation itself. Obviously, if you have a tubular damage and you can't concentrate urine, you will submit your kidneys to a higher level of stress if you work under the sun or are exposed to higher concentrations or toxins, or if you have more heat stress, you'll have a hard time trying to concentrate urine and keep the hemostasis if you have a tubular impairment. So yes, in my opinion, the intensity of the activity that you perform will affect your kidneys, but there's something else.
Pablo, do you have any comment?
No, I have just one comment. It's about, I just created a survey. So if people can help us to respond to reply to the survey, that would be great. Yeah. Hicimos una,
Okay.
sí.
Ajá. Go ahead, Pablo.
Sí, solo y también en español, que tenemos una encuesta ahí que en línea y pueden contestar a la encuesta, por favor. La idea principal de la encuesta es solo por conocer un poco más acerca de la audiencia y qué temas son los que les interesaría hablar sobre estas charlas. Y sí, solamente gracias.
Igual el sentido de la encuesta también queremos saber de la audiencia y en qué idiomas prefieren, porque dentro del seno del CENCAN hemos discutido si se hacen seminarios en español y en inglés, replicar los seminarios en ambos idiomas, o si la mayoría de la audiencia prefiere en español o viceversa. The aim of the survey is to try to identify what language do you prefer that this seminar can be held. And also, we want to know or to hear from all of you some recommendation about what kind of topic do you want, are you interested to hear or to know more about Mesoamerican nephropathy or CKDu as well. Our next webinar will be on April 20, so we'll be sending the invitation soon. We are working with the guest speaker right now to define the day. And the seminar will be about the histopathology of Mesoamerican nephropathy. And I'm 100% sure that the speaker will talk more about the lysosomal inclusion finding that was came out recently from a study that was conducted by Dr. Mar Debro and his team as well. So you are more than welcome to join to that seminar because we are going to talk more about this topic. And the CENCAN has at least a possible topic for seminar.